Okay, it is 11:30. Good morning, everybody, and welcome to Accelerate Your Telehealth Program, How to Move to Meet Market Demand. Many of you know our speaker today, but if you do not, Michelle Hager is the managing partner of Blue Cirrus Consulting. Since founding the company in 2010, 10-year anniversary this year, congratulations, Michelle. Michelle has led Blue Cirrus to become a trusted management consulting partner and leading telehealth advisory firm within the healthcare industry nationwide. She is dedicated to her passion for educating healthcare providers, advocates, and legislators on the behalf of the value of telehealth services. This webinar is being recorded for future viewing, and if you have any questions, please feel free to put them in the chat box and we will either answer them during or at the end.
Thank you, Amanda. Thank you, everybody, for being here today. One thing that you may have recognized if you've been to one of our webinars in the past is that we love a good theme associated with our webinar. And today is no different. Today, we're going to talk about how to accelerate your telehealth program and tell you about some of the important key functions of being able to move your program to that next level. Now that you may have just started that program or you're in that maturity stage where you're trying to get to that next level in your program. And we're also going to incorporate some of the space and rocket technology that we have available to us at NASA and SpaceX. So hopefully you learn a little bit about both telehealth and some of our exploration that we've done in our country. This is me and a bit about my experience. So I have over 20 years of experience in health IT. Work across the country with my team on telehealth and telehealth programs. I'm the chapter past president for South Carolina HIMSS. I've been the vice chair for public policy for HIMSS as well. And I'm currently on the advisory board for the Center for Telehealth Policy and e-law, and also on the industry council for the American Telemedicine Association and various work groups across the country related to telehealth. So this is the SpaceX rocket Dragon. And to me, this represents what you all are wanting to do, is to accelerate your program, go to that next level. And I may age myself, but the space shuttle I saw many times launch from Cape Canaveral, and it was amazing to see the SpaceX Dragon, I don't know what that's called, rocket, SpaceX actual capsule that's holding the astronauts inside launch from Cape Canaveral, now from just about the same launch pad that we saw the space shuttle launch from previously. So this represented a new evolution in space travel, in space exploration. And for those of you that may have watched this, the rocket that is separating from it was actually going to come down and land again on the ground, and they can reuse it. So this to me is really representative of what we're trying to do. We're trying to launch off, get to that next generation, be able to reuse some of the things that we've learned, like in the rocket, and be able to get into our next level of space exploration. So our agenda today to cover that and make sure that we're catching all of the areas that we need to be able to accelerate our program. We're going to talk about technology. We're going to talk about reimbursement, physician fee schedules that we see today that have been enacted post waiver. We're going to talk about provider etiquette, some of the patient considerations, as well as some communication tips and tricks to be able to gain adoption, as well as bring more people into your program. Over the last several months, we've seen the adoption of telehealth just accelerate at an exponential growth. So really taking that Dragon rocket and taking it to the stratosphere and beyond. and into the galaxy at that point. And this was data related to the week of October 4th. So we're very recent in the data that's being collected and reported out. So the Commonwealth Fund did some data on the COVID adoption, and you all probably have experienced this where the adoption level was so high. But what's interesting about this is the services, the specialties that are the percentage of visits across the entire spectrum of telemedicine visits. Behavioral health being the overwhelming majority at 41%, and some data that we see is almost over 50%. Endocrinology, rheumatology, obviously with our endocrinology folks looking at some of our chronic disease management, as well as rheumatology. So it's interesting how this kind of scales down. And what I find interesting is dermatology is actually really low. My thought on that is that we probably did not pay as much attention to our dermatological issues at the time during this COVID spike, and we were more interested in the more acute issues that may have happened to us as a society. So that dermatological number was pretty low. Normally that would be fairly high, but definitely demonstrating that behavioral health is off the charts. In addition, the Fair Health organization, fairhealth.org, which has great information related to the volumes of claims. This is over 32 billion privately billed medical claims over the entire United States. You can actually look at it by region, unfortunately not by state, but by region. You can see the different regions there in the far right corner. And what's interesting to me about this data that I'm showing you is the number of claims in the far right corner, the number of claim lines that we saw from 2019 versus 2020, the percentage change of telehealth. This is the telehealth tracker. So the number of percentage claim lines that we saw change is over 3,000% increase from September 2019 to September 2020. So just absolutely exponential increase. Urban versus rural, just below that, we can see that the numbers of adoption were fairly low, very low at 0.7, 0.07 and 0.17. Now we're exponentially increasing that up to 5.5, and in some cases in rural areas, 3% of overall claim lines. What we typically see is the total visits in an institution landing now somewhere around 20-25% of all visits that you are seeing in your patient base. The other interesting thing that I think is interesting here is in 2019, and down at the bottom in the top 5 diagnoses, in 2019 in September, mental health conditions represented 34% of those claims, those telehealth claims, and 20% represented acute respiratory diseases. Things like flu were starting at that time in September of 2019. But in 2020, we still have mental health conditions being the overwhelming number of claims that we're seeing produced. However, respiratory and acute diseases and infections are much lower. And I think that's a factor of the flu season not being a high flu season because of all of us social distancing and doing some of the things that the CDC is asking us to do. So again, this is continuing to show you that behavioral health, mental health is a huge area for you to consider as part of your telehealth program. If you don't already have a behavioral health program, this lends itself so easily for both therapies. As you can see, the top 5 procedure codes that were identified both in 2019 and in 2020 are very close. Most of the psychiatric services, psychotherapy is 60 minutes here in 2020, especially some of the other physician telephone visits and office visits that are very low, more medication checks, things like that. In med management. So good data that we can find here on Fair Health. You can again slice and dice this at your leisure. More information that we see as we look at these numbers, each of those 5 diagnoses by month, as we track it from February to September, we see that mental health has just gone from February to 33, top 33 of the total claim percentage of the total claims. And then in June, July, and August, we can see that mental health has increased significantly. What's interesting again is, we've got soft tissue is much smaller along the way, but those are staying pretty steady throughout the telehealth timeframes, but the mental health is absolutely off the charts. We still have barriers to adoption. We're going to talk about these barriers to adoption and how they affect, even today, us achieving that SpaceX level of exploration. So licensure is still an issue, although we know that the medical licensure compact is definitely moving things forward. And what we see, interestingly, is that we are seeing organizations and legislators saying, if you don't participate in medical boards, if you don't participate in the state licensure board, then we are going to actually penalize you. So that'll be interesting to see what happens with state medical boards that are currently not participating in the medical licensure compact. Reimbursement moving forward, lots of people ask what's happening with the PHE. We do see obviously that continuing into at least the fall, and I'll talk a little bit about that. Broadband connectivity continues to be a challenge, and security and privacy concerns. So all of these challenges cause us to have our goals, what seemingly to be out of reach. We are way outside of our galaxy. This is the Milky Way galaxy. We're way outside of our galaxy. We're not able to get to the Earth. We're not able to get to the center of our galaxy and to be able to reach to the goals that we want to reach. So let's talk about how we're going to get there through licensure and reimbursement. This is a key aspect of being able to launch your program and accelerate that program, legislation, and reimbursement, launching your program to the next level. We do have some reimbursement challenges across the country. However, if we were to look at this state map previously, it would be the opposite. Most of these states would not have telehealth reimbursement or telemedicine reimbursement laws in their states. And now we are seeing majority of them are. And even in my state where I am in South Carolina, I talk about this often, even though we don't have a parity law, we do have sort of an agreement between the payer and the health systems that they will pay for the telehealth services to a large degree. But we still have work to do. And this is only the current scenario with the laws that we see and the legislation that we see. If you don't currently follow CCHP and the information that comes from CCHP, it's actually a great resource for you to continue to follow the legislation in the various states that you might live in. The waiver and billing reimbursement that we see both during the PHE and post-PHE, this is a slide that I developed along with my friend Carol Yarborough, who we did a presentation with recently. We talked about what would we see during the PHE and what would we see post-PHE in terms of reimbursement, both inpatient and outpatient. So during the PHE, obviously geographic site limitations are waived. Not sure that's going to continue as we go beyond the PHE. There seems to be some efforts. There seems to be some movement towards continuing the geographic or waiving the geographic site restrictions or finding some ways to get around that, calling the services a little bit different so they're not subject to the geographic site restrictions. But we do still see that continuing, and it will be back to normal or back to the original site restrictions for geographic urban versus rural if we don't see a legislative change. We can, during the PHE, bill normally when we're on the telephone versus a video visit or at home, for example, but we will see some of those CPTs revert, and we may not be able to admit patients, obviously via telemedicine in post PHE. Some of the during the PHE, you can see the admission codes there, 99223. But we also see some of the commercial insurances following, but we are seeing states starting to collapse that as well and providing or requiring some additional back to their original laws related to coding and allowables for telehealth. On the outpatient side, again, the geographic site limitation has been waived during the PHE, which is great because home can be allowed as an allowable site, which is fantastic. I think there's a lot of effort and interest in having home be an allowable site. There are some additional codes to maintain the health equity and care while preventing the spread of COVID. We know that telephone codes are still audio only. Those are still allowable through the PHE. We see that continuing for some time, but post PHE not continuing to see the telephone or audio only codes, although we did see in the new CMS physician fee schedule some allowables for telephone codes. And so there are some facility charges there at the bottom. You can see the codes related to facility charges, the Q codes there. But will home continue to be on the post PHE side? Will it continue to be a valid originating site? Right now, only for home dialysis and substance use disorder treatment, but we'll see. We'll see what will happen, and it will revert unless Congress passes legislation. So the waiver represented really just this one engine, right? We were able to sort of wipe everything clean, and the engine was able to run. And this is a Merlin engine that is from SpaceX. So SpaceX developed this Merlin engine for them to be able to launch the Dragon orbiter into space through the rocket that we saw that was dropping down to Earth. This is just one of those rockets. This to me represents the PHE and where we saw just a lot of power, a lot of emphasis happening related to telehealth, and we were able to see some of the changes that occurred because of that. However, when SpaceX is actually launching, when the Dragon module or orbiter is actually launching, it's not one Merlin engine that we're utilizing in that, it's many. And you can see each of those Merlin engines are there at the bottom of the rocket booster that's at the bottom, and the SpaceX Dragon at the very top where the astronauts are actually located. So we need this level of power in order to be able to continue to accelerate the programs that we have across the country and accelerate the legislation. So we need actual legislative change. We need this kind of firepower to launch us into outer space and into other parts of our galaxy. So how much legislation have we seen change over the last year? We've seen from 2019, which is in orange, to 2020, we've seen broadband, slight difference, cross-state licensing. We've seen significant change there, demonstrations, some significant change there. Medicaid reimbursement hasn't really changed. Network adequacy, unfortunately, has not changed. Online prescribing, not changed. Private payer reimbursement, big change between 2019 and 2020. And again, this is enacted legislation. So that means that we do have this legislation in place. It's not dependent on the PHE. And of course, regulatory licensing, we know we talked about already the medical licensure and the medical boards may be potentially resistant to the penalties that could be enacted if we don't move towards participating in the medical licensure compact. So still some work to do there. In addition, Foley just put out an article, which I think does a great job of explaining the new CMS changes, the Medicare fee schedule changes that we saw happening this week, which is a big move forward. This is part of that Merlin engine, grouping that we need to be able to launch forward. These are actual permanent changes to the physician fee schedule, and it does have a huge impact on adoption and continued use of telehealth in the future, because I know a lot of us that are in telehealth are concerned that if adoption goes back to the original levels, that we have some challenges in order to be able to continue those telehealth programs forward and show sustainability. So let's talk about those CMS physician schedule changes that we saw just come out in the last few weeks. We have direct supervision that can be done via telehealth for nurse practitioners. So indirect and direct supervision for nurse practitioners can be done via telehealth, which is great. This is a time-limited study. They want to be able to collect data and make sure that this is going to be appropriate long-term, but it's huge. So if you're a nurse practitioner, or if you have nurse practitioners in your group and you potentially have a doctor who is supervising them and they may be in far-flung areas and you're concerned about that, that certainly happens in my state, for example, where the barrier islands of South Carolina have typically nurse practitioners working in them, and the physicians may retire and then they don't have a supervising nurse practitioner or supervising physician for those new nurse practitioners. So this is a huge change in movement towards utilizing the advanced practice professionals at the top of their license. We are extending audio only assessments, so virtual check-ins. You can see the code related to that. And this code is a crosswalk to 99442 when additional time is needed. So if that particular patient is more complex and you need a little bit more time, you can use that crosswalk CPT code to help you bill a little bit more on that visit, because it does have a complexity level. Geographic location restrictions do not apply to the audio only assessments as well. There are some frequency limitations that have been relaxed related to nursing facilities. So it used to be that skilled nursing facilities could only bill the visits every 30 days. They've shifted that to every 14 days. So there's a real improvement there. Again, that's firing that engine for us to continue to utilize telehealth in places that we already know do a great job and be able to reach those patients. So in this case, if you've got a primary care doc or geriatrician that reaches into these nursing facilities, particularly now during COVID, and you want to do that via telehealth, you can do that every 14 days now rather than just every 30. For new practitioners, for practitioners that don't currently bill E&M code, there are a couple of codes that are added to your list, and there's more than this, but I listed these for today. But for the store and forward code there for remote assessment, including interpretation, as well as virtual check-ins, which are those 5 or 10 minute visits, And again, if you need that more complex visit, then you can use the other extended audio only collection if you need to, but virtual check-ins, doing a video visit, that 5 or 10 minutes. I'm a big fan of this virtual check-in code, or this virtual check-in option, because we currently probably do this for free, or our docs are not doing that follow-up, or we're seeing no-shows in those areas. So this allows you to recapture revenue where you're already losing that revenue and it's not available to you. So again, firing that engine for you to be able to reach where you need to reach. But we have black holes that exist, and those black holes can stop us, can suck all the light out of our life. And sometimes that is the Department of Justice. So the Department of Justice recently put together a case in September 30th. You can see is the date of this case, where over 345 defendants were responsible for $6 billion in alleged fraud and losses. This is the largest healthcare fraud case in Department of Justice history. What's difficult about this is, for those of us in telehealth, we know that there is not additional fraud in telehealth. There is just the opportunity, just like we see in other types of healthcare. Unfortunately, there are bad actors both in telehealth and in face-to-face care. But this can have a chilling effect on your telehealth program. When organizations see that the Department of Justice and the OIG, as well as OCR, have looked at prosecuting folks for, in this case, this particular group of fraudulent cases had to do a lot with DME connection. So you're selling durable medical equipment as well as sort of the pain creams or the other types of pain medication associated with them. But this is a tremendous evidence of fraud in this particular, and people will be going to jail because of this, of course. But what's important to understand is the compliance element that you need to consider, taking a look at whether or not you have to have start and stop times for a particular service line. For example, here in South Carolina, we had an OIG audit and had some challenges related to behavioral health start and stop times. One of the biggest things related to that is following your policy and procedures. If your policies and procedures say that you need to have that or have a particular thing and you don't actually do that, the OIG will cite you and let you know that there's concerns about that. So often that doesn't result in fraud, but it does potentially result in you returning money to to CMS. So this can suck all the life out of your telehealth program, Department of Justice, but compliance is important, making sure that you understand all of the legislative efforts related to telehealth and staying compliant. So let's talk about that related to technology and privacy and security. So the International Space Station, this one I have made out of Legos, and our space shuttle kind of flying away. So it's a proof that you can do it with Legos. This is an example of all of the legislative changes that the United States has accomplished along with the global community. So this is a full organizational change that we see that resulted in the International Space Station. So when we think about all the pieces of technology that went into the space station, the same thing is true on the telehealth side. Thinking about what technology do you need? Is the hardware that you have, that you're purchasing, do you need additional hardware? Do you need additional microphones or additional cameras for you to post on, or even laptops or iPads or other types of personal devices? Make sure that the technology, you can utilize maybe existing technology so you can reduce the cost. This is an important element. So if you look at some of the pieces of technology or software that you might have or you might be considering to purchase, you want to look and see if you can actually use existing technology so you don't have to spend so much money. Are there some minor changes that you can make to the software in order to be able to use your existing hardware, for example? Do you need to create a new visit type in your EMR? And if you're setting up a dedicated telehealth space, are you allowing it to be done anywhere and when it's available? So are you doing it in a particular office location, or are you allowing them to do it at home, or even pulling to the side in a car if that's needed? These are important questions to ask as you are developing your new technology or considering purchasing your new technology. On the right side here, you can see you need to right size it for your organization. There are some pieces of technology that are just too big for you or too small for you. So make sure that the technology that you purchase or that you have is right sized for you. This will help you to be able to scale your program, and that will help you expand it and grow it and be that Merlin engine that we saw earlier. Be flexible, be willing to change based on their needs, based on your needs. So this vendor, wherever it is that you may be purchasing technology from or that you have technology, make sure it's flexible and that your contract terms are equitable without any gotchas in your payment terms, which we have seen in some contracts where the percentage increase is pretty significant each year, year over year. You want those organizations to prioritize you and your services and the things that you need, and then it really become a partnership. So these are the things that become a launch pad for you. They also need to provide a significant amount of reporting and data for you to be able to measure your program and demonstrate its scalability and sustainability. Technology in the community is a huge challenge. I want you to kind of look at the top of this water tower, and you can see there's a whole infrastructure that's been built at the top of this water tower. More often than not, what we find is that urban areas have sufficient technology. They meet the FCC requirements for bandwidth, but rural organizations in rural areas do not. And a way to accomplish extending that technology or extending that broadband is to put these towers on top of water towers in schools or on top of abandoned television broadcasting towers and extend the broadband out into these areas. This can be done and can be funded by the FCC and some of the FCC grant funding that we see happening, and is also very easily paid for and very easily done. So the health system or hospital could extend your broadband access into the community to be able to reach those patients where they don't have broadband access to be able to support a video visit. Or in my family's case, in some places, they have to walk into certain places of the house in order to be able to do a visit. And that's not going to be conducive to all the types of visits that you may want to do with your patients. But there still are other patient technology challenges. As you reach your patients, you may see that those patients have data limits. So one of the challenges and one of the places where we see telehealth programs falling down is when we depend entirely on patient technology and smartphones. And that's easy to say, right? 94% of the population, or somewhere north of 90%, have some kind of a smartphone. But that doesn't mean that they can support a telehealth and medical video visit. They have data limits. They have connectivity problems, as we've already talked about. They have poverty. In some cases, many of them don't have the level of technology that's needed to be able to support a video visit. Those patients don't necessarily want to add an app to your device. So when you think about the technology that you need to purchase, consider that you want this to be so easy for the patient. If it's easy for the patient, support goes down. So don't ask your patients to add an app to their devices. None of us wants a hospital app on our device, right? We want get our music and get our movies and get our Amazon and get our whatever. We don't want to have the local hospital on our phones. So don't ask the patients to do that. You're less likely to get adoption from your community. Just let them reach the telehealth visit through a text base or a link that you send to them, and those visits are easily done and no application is added to their phone. Some have varied technology. Some are Samsungs, Androids, iPhones, all different types, as you probably are aware. What do you do when you have an emergency during a visit? Or what do you do when you have a patient belligerent or behavior issues during a visit? You need to document that through your policies. So when you have an emergency in your visit, you need to make sure that you're not just calling 911, because you need to know where that patient is. You can't call 911 from where you are. It needs to be where they're located. And you need to be aware of that before you start the visit. So it needs to be part of your process. What about behavior issues on a virtual visit? It could be anything from cursing to violence to anything. And what are you going to do in that case? So my question to you would be, what do you do with that if they're in the office? If patients are in the office and are belligerent or are cursing or are treating your clinicians poorly, you would end the visit and ask them to leave. It's actually easier in a virtual visit. You would end the visit and you don't have to worry about trying to get them out of the building. They're already gone. So additional caregivers might be needed also for translation services. You may want to add other family members in on a visit. Make sure your technology works. You might want to have a psychologist and a patient and their family member and a translator. So does it support all of those elements? And you might say, well, I don't need that today, but you need to be able to scale it, because purchasing technology over and over and over again is expensive and not scalable. So let's talk about provider etiquette and some patient considerations as you do a visit. This is some of the most important pieces of creating a successful program that your providers will adopt, that your patients will appreciate, and rises to the level that you currently have in your face-to-face visits. You want to make sure that it's at the same level that you currently have. So training is important. With the NASA astronauts, they don't just suit up and go. They train and train and train. So in this case, they're going into a pool of water to learn what it feels like to be weightless and how to utilize their equipment in a weightless environment, and how to move, and how to make sure they stay safe, and how to speak to each other, how to communicate, what to do in an emergency. All the same things that you would need to do in a telehealth visit. How are you going to communicate to other clinicians? What if that clinician has a problem? Who are they going to reach to? What if there's a technology problem? That has to be solved immediately. And we need to get those clinicians that are utilizing telehealth used to doing telehealth. So we need to practice. We need to do this training. We need to get in the water, and we need to understand how to move properly in a weightless environment, i.e. our telehealth visit. Do we show the top of our head? Do we look directly into the camera? Do we have a cup of coffee next to us? Do we drink our Gatorade while we're talking to the patient? Are we in sweats? We're not in any of those things. Think about your presentation considerations. If you're at home, then you need to be in a private area that's free from interruptions. And everyone understands during COVID that there are some interruptions, but we're planning for post-COVID. So how are we going to make sure that we don't have dogs coming in, we don't have people walking past? That's important, and set that as a requirement for your clinicians. Present as if you're in the office. So this is the new astronaut wear. This is a recent picture of the SpaceX Bob and Doug when they did their big adventure out on the SpaceX Dragon the first time. And look at their wear. They're not going into space in a suit jacket and tie. They're wearing their astronaut suits. And if they came out in anything other than these astronaut suits, we'd wonder what the heck was going on. By the way, just note, that's the astronaut suit. That used to be the astronaut suit. So innovation is happening in this space area as well as telehealth. So wear the appropriate clothing that you would wear just as if you were in the office. Watch your broadband at home. If you don't have bandwidth enough to support a video visit on a regular basis, increase your bandwidth at your home if you plan to do that on a regular basis as a clinician, or if you are going to be the person supporting patients or supporting clinicians that are working from home, make sure that you test their bandwidth and that it's at a sufficient level for them to continue to have video visits. Also considering that other people in the home might be using that broadband as well. So, are we seeing folks using Xboxes or streaming videos at the same time? So we want to make sure that we have either a separate broadband that doesn't interrupt that virtual visit, or that we have sufficient levels of broadband that we can do a visit without being affected. No food or drink in the camera. We don't see Bob and Doug here having a drink before, even a water before they head off to space. They've already done that. Take your drinks before your visit. Take your food and have that during your lunch times as you would normally. And I always talk about avoiding the nostril shot, making sure that where the camera is not too low and that it is looking up into your nose. Make sure that your camera is at eye level. So raise it up on a book or a few other pieces of boxes or anything like that to raise the level of either your phone or device so they can be at eye level. And it seems like it might be a little high sometimes, but it isn't. Take a look at what people are doing on TV today. You can see where their faces are, that they're doing proper technology placement and face placement in a video. Training, training, training. We've already talked about how important that is, but create a short training video, 1 or 2 minutes on how to, that you can even create on your iPhone and your own phone, to be able to educate people on how to do telehealth, educate your users or yourself. Do you have resources for one-on-one training if someone needs that? Make sure that you have side-by-side resources or training if you need that, and tip sheets with FAQs for the providers and staff to refer to after you're live, because you're not going to be there necessarily with every single visit, and you shouldn't be. So create a quick reference guide or pocket guide, put something on electronic that they can pull up real quick on their phone to remind themselves, oh yeah, that's how I do a visit. And then what about support? We need a dedicated support line for those clinicians and for those patients to be able to reach while they're in a visit in case there's an issue. And clinicians don't need to be the technology support line. So create a line and make sure that single line is there to route calls, not your normal help desk process, not your normal, 24 hours we'll call you back, but inside of your normal help desk process or support process. So it's inside of that, but everybody knows it's telehealth, so we need to respond more quickly. And then provide some one-on-one support for clinicians that have low usage. So get your reports, look at them, see who's not adopting, and find out what the concern is. I know we've seen some docs that have said, we're too old, we're not doing it. And if that happens, we need to help them understand how, even if they're old, they can learn new tricks, right? So there are some easy things to do. I often recommend that we do some follow-up visits via telehealth. Those are really easy, particularly for pediatricians. How often have you done a earache or sore throat follow-up? Patients don't even come. They feel better, so they don't come back to the doctor. So do these via telehealth, do those in a virtual check-in just to see how are things going, how are you feeling, and they get used to a telehealth visit, and perhaps we'll add some additional services over time. So communication. This is how NASA communicates with the International Space Station and communicates with the Dragon spacecraft, as well as Houston, SpaceX Mission Control, and NASA. So there are lots and lots of methods to communicate across the astronauts process here with Dragon and NASA, across the space travel. Because if they were to lose communication across these areas, if any of these yellow lines, for example, had a challenge and they weren't able to communicate, then the process would stop. And we know from seeing NASA communicating in the past that they will abort missions if they're not able to communicate properly at launch period. So communication is key with NASA and space travel, and that's true in telehealth as well. So create a communication process for all of your staff to make them aware that you've implemented telehealth. I can't tell you how many times we've been to organizations and half of the organization does not know that there is even telehealth happening. Now that may be different today with COVID, but I'm sure that there are still organizations and still places in your organization where they are not aware of the telehealth programs that you have in place. So create a communication plan, work with your marketing department to disseminate that communication and make it a nice, fancy, slick type of communication out about your telehealth programs. And as you have successes, as you see new telehealth programs being added, also create communications around that. People want to see that these new innovations are happening inside of an organization. We've talked about writing a script for your schedulers so they reach out to the patients and make sure they're aware that there's a telehealth offering. I know sometimes patients are saying now, well, I want to come into the office. I'm okay. We've managed it. We'll just wear a mask. Everybody will wear a mask. But we'll still see after the public health emergency, people not willing and also scared, and also those that want the convenience of telehealth. So we're going to have to continue to have our scripts and making people aware that telehealth is there and how it happens and how to support it and how to use that on a regular basis and schedule a visit. Email or message the patients about your telehealth offering. You probably have some other means that you're communicating about other improvements that you're doing in the office, and use those same means. Sometimes text, lots of folks are using text today. That's an easy way to get to folks, and you can just send links right inside that text. And then post those updates on social media. Lots of people are utilizing social media. So again, working with your marketing department is a really important part of that. And then you can incorporate right into your social media for the organization. And again, showing your successes in those same social media posts. So now you're getting closer to your goal. We're not out in the galaxy. We're even closer to our goal, and we may be able to launch off and get back to the earth, so we can launch our telehealth program, accelerate our telehealth program across the galaxy as far as we want to go in your region, in your catchment area, across the universe if that's needed. As always, we want to thank you for our healthcare heroes. We're facilitating and helping healthcare folks, but you all are on the front lines, and we appreciate all the work that you do and all of your colleagues that do on a daily basis during this public health emergency, as well as all other times of the year. I'll take some questions now. This is my contact information. If anybody has any questions that you don't necessarily want to ask during the webinar, you want to put those into the chat, or we can unmute you if you do have a question, you want to ask it live, we can do that as well. Also, feel free to call my phone number here that's listed. And I would also encourage you, excuse me, to reach our website, blue-cirrus.com. We have lots and lots of information in our Knowledge Tsunami, including radio shows, which are essentially podcasts with lots and lots of professionals across the country in telehealth, as well as previous webinars and important articles that could be very helpful. All in one place, all free. And that concludes our presentation today. Any questions? We can see those in the chat.
Michelle, I would like to add that this is our last webinar for 2020, but we will be back in 2021. And thank you guys so much for joining us today. And everyone, please have a happy and safe holiday season.
Thank you, Amanda. Thank you, everyone.